My name is Dr. Caitlin Rubley. Today, we are going to talk about an emergency department quality improvement project for intravenous levetiracetam administration. I would like to thank my co-authors listed here at the University of Colorado. We have no conflicts of interest to disclose. Levetiracetam is a readily available, low-cost anticonvulsive medication. Recently, the established status epilepticus treatment trial assessed anticonvulsive medications. ESET compared levetiracetam, phosphenitoin, and valproic acid in children and adults with status epilepticus. There were no statistically significant differences among medications in success of seizure cessation and improvement in mental status. Doses were administered at a maximum of 4,500 milligrams or 60 milligrams per kilogram over 10 minutes. In an emergency department setting, rapid administration is important for treatment of life-threatening neurological disorders. However, there are other considerations for administration as well. Number one, rapid IV push medications are often favored by nurses compared with other routes of administration. One survey found 87% of nurses were in favor of switching from IV piggyback to IV push antibiotics due to less time spent gathering supplies, entering orders, or documenting secondary infusions. Number two, IV piggyback administration may take up to 60 minutes and utilizes additional resources such as IV tubing and infusion pumps. In one ED setting, pumps were frequently not flushed, and as much as 20% of medications may remain in the tubing, thus underdosing the patient. Number three, other delays in anticonvulsive medications include retrieval from a central pharmacy location due to preparation toxicity protocols, such as that with phosphenitoin. At the University of Colorado Hospital, phosphenitoin premix solutions were stored in the emergency department in order to offset the increased preparation time. The estimated compounded phosphenitoin premix solutions waste totaled well over $400 every month. And fourth, carrier fluid shortages have been well documented from climate-related extreme weather events. Sterile solution shortages were appreciated in the United States for months following Hurricane Maria in Puerto Rico. As such, we sought to compare usage, cost, and administration waste between IV push and piggyback administration of levetiracetam following implementation of an IV push protocol in one academic emergency department. A 3-month review of levetiracetam administration was done following protocol implementation using push administration doses up to 4,500 milligrams. The review quantified the number of push versus piggyback doses for all indications and evaluated cost of medications and supplies necessary for administration, including reduction in previously used phosphenitoin. Further details can be found below. This is a visual depiction of IV push setup on the left versus IV piggyback setup on the right. And this is the protocol we used and developed as part of interdisciplinary inpatient and emergency department teams. Over the 3-month study period, 137 patients received 142 doses of intravenous levetiracetam. The prescribing indication was seizure for 58% of doses rather than intracranial hemorrhage or mass. 36% of doses were given as push, as shown there in red, rather than piggyback. The majority of doses were at lower dose ranges. A total of 236,000 milligrams of IV levetiracetam was administered over 3 months in the ED. Estimated annual savings with transition of piggyback to completely push would exceed $25,000, as shown there in red. The amount of carrier fluid would be reduced and free IV pumps and pump times as well. The project certainly demonstrated initial success in transitioning to IV push administration and highlighted key opportunities for continued improvement in implementation procedures, cost savings, and waste reductions. When it came to usage, 36% of doses were administered according to the new protocol. There remains opportunity to improve. We noted challenges related to a global pandemic and competing priorities. For safety, 3 potential adverse drug reactions were identified, and this is consistent with previous studies. Just a reminder, black box warnings for phosphatidylcholine are there on the right, and even a rare complication of purple glove syndrome. Cost savings, modest cost savings were related to these changes, and again, should be considered in pharmaceutical practices in the future. Pharmaceuticals also represents a topic for healthcare systems to evaluate to support a healthy planet and operations, as the health sector accounts for approximately 10% of greenhouse gas emissions here in the United States. There are several strengths and limitations of this study, which I'm happy to discuss further. And just to conclude, again, significant opportunity to improve practices. Recommend using oral medications when able, work as part of interdisciplinary teams, expand implementation science, and incorporate climate smart healthcare into pharmaceutical policies with international collaboration and actionable disaster plans to best meet supply demand mismatches and provide equitable distribution of resources, even in the face of scarcity. I would like to acknowledge all the participants in this project and the University of Colorado collaborators.
Good afternoon. My name is Patrick Malloy, and I'll be presenting our electronic poster on behalf of Amy Wang, Trin Bu, Stephanie Zach, Lauren Howell, and Jess Corio. Our poster stems from an abstract which we wrote, which is entitled Characterizing Hypoglycemia Following the Use of IV Insulin for the Treatment of Hyperkalemia in ESRD Hemodialysis Patients in the Emergency Department. In our emergency department, we see a high volume of ESRD hemodialysis dependent patients. As we know, hyperkalemia is a common complication in patients with end-stage renal disease who require hemodialysis and can lead directly to cardiotoxicity if left untreated. Intravenous insulin is one of the most reliable drug therapies available for the acute treatment of hyperkalemia. Our objective of the study was characterizing the risk factors for development of hypoglycemia in HD-dependent ESRD patients being treated with IV insulin for hyperkalemia in the emergency department. The primary adverse effect, as we know, of insulin is hypoglycemia, and that can lead to increased morbidity and mortality. Previous studies had identified the potential risk factors of hypoglycemia following insulin administration. However, these studies did not exclusively evaluate end-stage renal patients requiring hemodialysis, and that is what our focus is on this abstract. Our method was a retrospective chart review evaluating the ESRD patients from Emory University Hospital Midtown from January 1st, 2018 to December 31st, 2019. The inclusion criteria were end-stage renal disease patients on hemodialysis, a serum potassium greater than or equal to 5.5 milliequivalents per liter. The patient must have received IV regular insulin for the treatment of hyperkalemia, and there must have been a recorded baseline blood glucose prior to IV insulin administration. Exclusion criteria included a patient being less than 18 years old, a blood glucose value greater than 70 milligrams per deciliter for 6 hours after the insulin dose, no documented blood glucose within 6 hours of IV insulin administration. What is the outcome of our study? Well, we found that the incidence of hypoglycemia was 3 times higher in the end-stage renal disease population than in the general population. Risk factors for hypoglycemia include patients who are insulin naive and those receiving doses greater than 0.1 units per kilogram IV insulin. Patients who developed hypoglycemia, defined as glucose less than 70 milligrams per deciliter, or severe hypoglycemia, defined as glucose less than 40 milligrams per deciliter, required resuscitation with IV dextrose, which was given in a dose of 25 grams. 20% of those patients with hypoglycemia received multiple doses of dextrose, and 25% with severe hypoglycemia also received multiple doses. In conclusion, our study and abstract has led to a change in the order set, which is used when providing insulin and glucose to patients with known hyperkalemia in our emergency department. The insulin dose was adjusted down, and the dextrose dose was automatically added to the medication profile of a patient in order to decrease the number of hypoglycemic events. Our goal is to continue studying these hypoglycemic events in order to decrease the frequency of their occurrence. We have also incorporated physician and nursing education in order to further prevent these events from occurring. Ultimately, our plan is to continue studying this and to provide further research in the future to risk factors of developing hypoglycemia and ways to prevent them from occurring. Thank you very much for your time, and I look forward to answering any questions you might have.
Hello and welcome to our lightning abstract presentation, Improving Emergency Department Discharge Instruction Readability. My name is Daniel Narin. I am an emergency medicine PGY2 at Hennepin County Medical Center, also known as HCMC.
And my name is Zach Davidson. I'm an emergency and internal medicine PGY2, also at HCMC. Low health literacy leads to longer hospitalizations, increases ED utilization, and increases cost. Guidelines from the Agency for Healthcare Research and Quality recommend health information be written at a 6th to 8th grade reading level. However, data show that most health information for patients is written at a 10th grade level or higher. This represents a gap between guidelines and practice. Importantly, an estimated 50% of ED patients in a 2011 study had less than an 8th grade reading level. At our institution, this topic was investigated in 2008 and demonstrated that 15% of patients had low health literacy based on a validating screening tool. However, we suspect this number is significantly higher, as only 25% of patients who were screened participated in the study. The disparity between guidelines and practice and the knowledge that a significant amount of ED patients have low health literacy prompted us to develop our QI project.
A 2013 study at our institution investigated whether different modalities affected rates of filling antibiotics after ED discharge, but did not assess readability of those instructions. We found few published studies that looked at the readability of discharge instructions. However, one study from 2017 was conducted in an inpatient pediatric setting at Cincinnati Children's Hospital. This study defined readability as below 7th grade on the Fleisch-Kincaid readability scale and demonstrated a successful intervention after which they improved readability of discharge instructions from 13% to 98% and sustained it for 4 months. Per our literature review, there have been no prior studies of this kind conducted in an emergency department. Given the paucity of prior work in this field, we built off the Cincinnati group's work when designing our QI project.
We conducted our QI project at the HCMC ED, a level 1 trauma center located in downtown Minneapolis, Minnesota, with over 100,000 annual visits, serving a high proportion of Medicaid patients in a large refugee and immigrant community.
The Fleisch-Kincaid readability scale was used to calculate the grade reading level of discharge instructions. A convenient sample of eligible patients over a 4-day period was determined by EHR chart review, excluding primarily patients with no written discharge instructions or patients who eloped before discharge. We conducted our intervention and after 3 months, compared the average grade reading level from the pre- and post-intervention periods, as well as conducted a multivariate regression analysis to evaluate if patient, visit, or provider variables were associated with a higher grade reading level.
A provider education session was given at resident conference to announce the project and its goals. Reminder cards, which can be seen at the bottom of the slide, were posted in ED workstations, prompting providers to write in simple language, avoid medical jargon, and use a simple discharge template which we created, accessed using a dot phrase in Epic. Tip cards were distributed for residents to put on their badges. The text on the tip card includes an example of discharge instructions for a patient written at both 7th grade and 12th grade reading levels, as a quick reference on shift.
We included 91 discharge instructions from individual patient encounters in each phase. Our statistical analysis found no association between patient variables such as age, gender, or race with grade reading level. There was also no association between visit complexity with grade reading level. EM PGY2 and EM PGY3 through 5 providers were associated with a higher grade reading level. The post-intervention period was associated with a statistically significant lower discharge instruction grade reading level. The median grade reading level of discharge instructions decreased from 9th to 8th grade. Most importantly, the percentage of instructions meeting Agency for Healthcare Research and Quality guidelines increased from 39 to 64%.
In conclusion, after a simple and low-cost QI intervention, A majority of discharge instructions newly met AHRQ guidelines for grade reading level. Patient and visit variables did not have an association with grade reading level of discharge instructions. However, senior EM residents were associated with an increased grade reading level. Major limitations of our study include the retrospective nature and convenient sampling. Fleisch-Kincaid was used because it is widely accepted and open access. However, it does have a narrow definition of readability.
Looking ahead, we plan to incorporate our discharge instruction template into the Dispo tab of our EMR, assess the durability of our intervention, and expand this intervention to other settings in our institution. Considerations for all emergency departments include awareness of the national guidelines for medical information, assessing the average grade reading level of the patient population served, and finally, formal training for providers centered around communication of health information. Thank you for your time and attention.
And we will now take your questions.
Hi everyone, my name is Alex Finch and I'm an assistant professor and associate program director at the Mayo Clinic Emergency Department in Rochester, Minnesota. I'm excited to discuss our project, Cause for Alarm, Reducing Misinterpretations of Audio Alarms in the Emergency Department with you all today. Before continuing with the presentation, I wanted to take a minute and recognize all of my co-authors for their significant contributions in developing the project and to sincerely thank them for their work. As a team, we have no disclosures. Alarm fatigue is a significant threat to patient safety, and the Joint Commission added reducing harm associated with clinical alarm systems to their national patient safety goals. Studies indicate that emergency and critical care providers are exposed to hundreds of alarms per day, the majority of which are non-actionable. This may raise the chance that providers will become desensitized to critically important alarms. There have been patient deaths which have been attributed to alarm fatigue. A recent study in the American Journal of Emergency Medicine found that during their period of observation, 0.8% of alarms changed management, and that staff did not observably respond to the majority of alarms. Alarm fatigue is a phenomenon where members of a medical team may ignore or fail to take action on an alarm. This is a multifactorial problem which can be related to the number of alarming devices, as well as the number of alarms for which no action can be taken, among other factors. We work in a high acuity emergency department with frequent code alarms that some staff feel is similar to other tonal alarms in the department, which really sparked our interest in this question. We became interested in alarm frequency as well as volume in generating our hypothesis. In generating the concept for the project, I actually went to our buildings and grounds crew and borrowed the equipment they used to establish OSHA noise compliance. This is our calibrated SoundPro sound level meter. Then I walked around the emergency department and measured several of our daily clinical alarms, following the manufacturer's instructions of the SoundPro. And just wanted to show you some of these values when compared against standard values from the OSHA website. The y-axis here is decibels. In evaluating how loud these clinical alarms are and how frequent, our team established the specific aim of our project, which was to evaluate if adding voice prompts to clinical alarms would increase recognition of high-stakes alarms in the emergency department. We conducted an interventional pilot study involving a convenient sample of 139 ED staff members at a quaternary care emergency department with 77,000 annual patient visits. The study was conducted from April to May of 2019. Volunteers were asked to identify recordings of alarms from the emergency department with and without voice prompts. A mix of high acuity alarms, for example the code blue alarm, as well as low acuity alarms, including bathroom or nurse call lights, were tested. Data were summarized with descriptive statistics and 95% confidence intervals. Among the 139 staff who completed the pre-intervention survey, 17% were ED attending physicians and 11% were EM resident physicians. The remainder included nurses, pharmacists, and clinical support staff. 93 staff members completed the post-intervention survey. Correct interpretation of our code blue alarm was 65% among all staff at baseline without a voice prompt. With the addition of a voice prompt, correct interpretation of the code blue alarm improved to 88% among all staff. 69% of attending physicians and 76% of resident physicians correctly identified the code blue alarm at baseline. This improved with addition of a voice prompt to 95% correct among attending physicians and 86% correct among resident physicians. Among the 48 participants who misidentified the code blue alarm tone, 7 participants, representing 15% of the group, with a 95% confidence interval of 6 to 28%, misidentified it as a low acuity alarm. Examples included bathroom alarms or nursing call lights. In addition, 13 respondents indicated that they had no idea what the alarm meant. This represented 27% of this group. At the end of the exercise, we also asked people to provide subjective feedback. 58 staff members wrote subjective comments. Among those, 50 left feedback that was categorized as positive. We included some examples on the slide. Among those, 3 that felt that the voice prompts were not helpful. 1 cited that voice prompts might be deleterious to the patient experience, and another felt that voice prompts were useful but should not be automated, but should be conducted by the front desk staff. There are numerous limitations to this study. As it was a pilot project designed to evaluate participant recognition of alarms, there was a small sample size, and so there are limitations to the generalizability of our data. Participation was voluntary, and there were participants who were lost in completing the post-intervention survey, which also limits interpretation of our results. Finally, the survey was designed to mimic alarm sounds. However, this was outside of routine clinical care, and therefore other contextual clues that people might have about the alarms were not applicable. In summary, recognition of critical alarms improved with the addition of a voice prompt. When a critical alarm was interpreted incorrectly, 42% of respondents either had no idea what the alarm meant or confused a high acuity alarm for a low acuity alarm. In general, feedback on the voice prompts was positive. Briefly, I want to acknowledge the references that made our work possible. Thank you so much for your time and attention watching our presentation.
Today we are presenting experimental evidence of the effect of patient behavior on emergency department physicians' emotions, attitudes, and clinical judgments. A robust psychological literature suggests that emotions strongly influence our behaviors, attitudes, cognitions, and actions, yet little research has been conducted on the effect that emotions may have on a provider's cognitive and diagnostic processes, especially in emotionally evocative settings such as the emergency department. Recent work by Isbell and colleagues sought to establish the first data-driven model of emotion-eliciting factors in the ED. This word cloud depicts the emotions most frequently mentioned by providers in a large qualitative study sorted by size. However, very few studies to date have used experimental methods to directly investigate the possibility of a causal relationship between provider emotion and clinical judgment. Thus, the main objective of the study is to experimentally manipulate patient behavior and test its effects on medically relevant clinical judgments and outcomes. We hypothesize that irritable patient behavior will lead to greater physician anger, diminished provider expectations for positive outcomes, and increased risk of diagnostic error.
We recruited 82 emergency physicians from the United States. Our sample was around middle age and highly experienced. Participants completed an online diagnostic reasoning task. Within the task, physicians first reviewed an electronic health record of a fictitious patient complaining of a physical symptom presenting with or without a comorbid mental illness. Here's a screenshot of an EHR for Jill Buckley, who's complaining of a migraine. The red font is present only in mental illness conditions. Next, physicians watched a 4-minute video of the patient interacting with the physician. The medical information and script were the same, but the patient behaved either calmly or irritably.
Yeah, I went to the ER a few days ago. They didn't really do much for me. Yeah, I went to the ER a few days ago and they basically did nothing for me.
Physicians then reviewed a physical exam, had the chance to order, receive, and review 2 rounds of test results to aid in diagnostic reasoning, and then rendered a final diagnosis alongside responding to clinically relevant measures. Jill Buckley's correct final diagnosis was a venous thrombosis, but we created 4 different clinical cases. Participants completed all 4 diagnostic reasoning tasks in a random order, each varying patient behavior and the presence of a mental illness. To ensure findings were not idiosyncratic to a specific diagnosis, patient type, or case characteristic, participants were randomly assigned to receive one of 4 different patient case sets. This allowed for the testing of our primary question, the effect of irritable versus calm behavior on clinical judgments, and the testing of our secondary question, whether this relationship varied as a function of comorbid mental illness diagnosis, using 2-way repeated measures ANOVAs. Patient case set was initially included as a between subjects factor, but after verifying the absence of consistent effects, was omitted from final models. Across all outcomes, we found consistent effects of irritable patient behavior and inconsistent effects of mental illness diagnosis. As such, in this section, we collapse across the mental illness conditions. Emotion profiles, while discrete variables, are presented as line graphs to aid interpretation. Perhaps unsurprisingly, physicians reported that irritable patients were angrier, more anxious, and marginally more sad and depressed as compared to calm patients. Irritable patient behavior also resulted in physicians reporting greater anger and greater unease themselves relative to calm patients. Sadness did not vary as a function of patient behavior. Irritable patient behavior also diminished physicians' positive emotions as well, as physicians reported being less happy, calm, empathic, and importantly, less engaged as compared to when diagnosing calm patients. Physicians' perceptions of the patient were also affected by irritable patient behavior. Irritable patients were rated as less likable and cooperative, and rated to be worse historians as compared to calm patients. And physicians had lower expectations for positive outcomes for irritable patients as compared to calm patients, including expected adherence to treatment, recovery likelihood, and likelihood to return to work. Regarding diagnostic error, physicians were marginally less likely to express confidence in their diagnosis and less likely to express an awareness of what's going on in a case if patients were irritable rather than calm. We found no effects of patient behavior or psychiatric condition on objective measures of diagnostic accuracy as scored by an expert ED physician. Our results suggest that irritable patient behavior may be a salient contributing factor to negative physician attitudes towards patients. While we find inconsistent effects of mental illness condition, it's important to note that our manipulation was subtle, consisting of only an additional diagnosis on the EHR. Despite these null findings in experimental paradigm, documented care disparities do exist for these groups. While we did not find effects of patient behavior on diagnostic accuracy, negative physician attitudes may have implications for patient safety. Considering the likely possibility that patient behaviors affect clinical care outcomes is necessary for future intervention work.
This is pharmacist-based medication reconciliation as part of the emergency department admission process, utility and resource utilization. The authors have no financial interests, professional relations, or conflicts of interest associated with any products or devices discussed in this presentation. Complete and accurate medication reconciliation is an important component in the prevention of medication errors. Pharmacists have been utilized to perform medication reconciliation in the emergency department and limit potential errors related to inappropriate medication administration. However, little research has been done to assess this process. The goal of our project was to evaluate the utility, resource utilization, and potential benefits of pharmacist-based medication reconciliation programs in the emergency department. This was an analysis of prospectively collected data from a 318-bed suburban hospital in which pharmacists performed a detailed medication reconciliation when a patient is placed on admission or observation status. A 1-month subset of data from this program, which has been active for 2 years, was utilized for this analysis. The data collected included age, number of patient medications, number of discrepancies, and time required to complete medication reconciliation. The data was analyzed to assess the number of medication changes, as well as the time required to complete this process. Missing medications or inaccurate medications were considered major errors. During the study, 618 patients were enrolled with a mean age of 66.6 years. The mean number of medications listed prior to the pharmacist review was 9.2. The The mean number of medication errors per patient was 6.9. Of these, 4.1 errors per patient, 59%, were considered major. The mean time for the pharmacist to complete the medication reconciliation was 25.4 minutes, with a range of 0 to 115 minutes. The time required to complete the medication reconciliation was positively correlated with age and number of medications that the patient was taking. Time to complete medication reconciliation was sorted by 10-minute intervals and compared to number of medications, number of errors, number of major errors, and age. Each of these factors increased with increase in time to complete medication reconciliation. However, there was a slight decrease in age in the last group. We think this is because the older patients tended to come from skilled nursing facilities with medication administration records. We are doing further research to assess this correlation. Some of the limitations of the study were as followed. The study was conducted at a single institution. Medication administration records were usually sent with patients from skilled nursing facilities, and this may have impacted the data in some of the patients in the upper age groups. In conclusion, pharmacist-based medication reconciliation performed in the emergency department at the time of patient admission identifies approximately 6.9 medication errors per patient. Despite the effectiveness of this process, it is time-consuming. Our study found that an average of 25.4 minutes was required to perform this process on each patient.
Hello, my name is Michelle Ryan, and my project is entitled The Impact of Patient Age on Pharmacist-Based Medication Reconciliation in the Emergency Department Admission. Of note, the authors have no financial interest, professional relationships, or conflicts of interest associated with any products or devices discussed in this presentation. Of note, improving medication safety is one of the Joint Commission National Patient Safety Goals. Incorporating pharmacist-based medication reconciliation in the emergency department is costly and time-consuming, but it may decrease potential medication errors. Identification of high-risk patient groups may focus this process and improve resource utilization. The objective of our project was to evaluate the effects of patient age on the resource utilization and potential benefits of a pharmacist-based medication reconciliation program in the emergency department. Our methods included an analysis of prospectively collected performance improvement data at a suburban hospital with 318 inpatient beds. A pharmacist-based medication reconciliation program has existed for 2 years in which pharmacists perform a detailed medication reconciliation when a patient is placed on admission or observation status. A 1-month subset of this data was utilized for this analysis. The data collected included age, number of patient medications, number of discrepancies, and time required to complete the medication reconciliation. The data was then analyzed to assess the number of medication changes as well as the time required to complete this process. During the study period, 618 patients were enrolled with a mean age of 66.6 years. The mean number of medications listed prior to the pharmacist review was 9.2, and the mean number of changes was 6.9. The mean time for the pharmacist to complete the medication reconciliation was 25.4 minutes, with a range of 0 to 115 minutes. There were significant differences across age groups in both error rate and time duration to complete the medication reconciliation. The highest rate of errors was in the 70 to 79 age group, and the 70 to 79 and 80 to 89 age groups had the longest duration. This graph depicts the amount of medications, the errors in medication reconciliation, and the time required to complete the reconciliation within specific age groups. The limitations of our study included that it was undertaken at a single institution. Medication administration records were usually sent with patients from skilled nursing facilities. This may have impacted the data for patients in the upper age groups and accounted for the lower error rate and medication reconciliation completion time in these groups. The conclusions of our study included the number of medications, medication errors, and time duration required to complete a medication reconciliation varies with increasing age. By identifying patients at high risk of medication errors, it may be feasible to focus limited resources on patients with an increased risk of these errors.